Good evening, everyone. This is Batul from IJCP, the moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. So, before moving on to today's session, let us have the introduction of our renowned stalwart. He is none other than the very renowned rheumatologist, Dr. Ved Chaturvedi, sir. Sir is MBBS, MD, DM, Senior Consultant at Sir Gangaram Hospital, and Vice President at Asia Pacific Rheumatology League. With Sir's wonderful insights, we are going to talk about the topic for today, which is simple diagnosis and management of rheumatoid arthritis. Before moving on to today's session, let us have a brief look on what the topic says. Rheumatoid arthritis is diagnosed through a combination of clinical assessment, blood tests for inflammatory markers such as C-reactive protein and erythrocyte sedimentation rate, and antibodies like rheumatoid factor and anti-CCP antibodies, as well as imaging tests such as X-rays or ultrasound. Management of RA includes a combination of medications like disease modifying anti-rheumatic drugs, non-steroidal anti-inflammatory drugs, and biologics to control inflammation and slow disease progression. Physical therapy, exercise, and lifestyle modifications are also important for maintaining joint functions and quality of life. So we will be knowing more about this topic with Sir's wonderful insights. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thanks for the kind introduction. So I'll be talking about this disease. Just a minute, why it is not moving? Rheumatoid arthritis. So rheumatoid arthritis is a disease. They must know that it's like neurology today. What is the basic pathology? So there are different. This is a joint. If the basic pathology, suppose, is in the cartilage, which is the most common disease of the, this is called as osteoarthritis. But if the basic pathology is in synovium, this is synovium, then the disease is rheumatoid arthritis. And if the basic pathology is in the tendon, that is the spondyloarthropathy. So they are different diseases. Today, what I am talking to you is the disease of synovium, which is called as the rheumatoid arthritis, which is different from, so rheumatoid arthritis, when we were a student, because that time no treatment was available, so patient used to come late, and actually we were told rheumatoid arthritis will come like this. So we were seeing patient like this, and there was no diagnostic test required. Everybody knew this has, it is something like suppose in dental. Earlier, my father was as a dentist, suppose, and if the whole tooth has become cavity, so that is a complication. So this was actually not rheumatoid arthritis. This is a complication of rheumatoid arthritis. So now what has changed? Because now we can diagnose it early. And how we diagnose it early? First thing, by making aware to the people, like I'm doing today. I'm discussing with you. So those people who are listening, they'll be aware of what I am teaching. So diagnosis should be early. That is number one. And diagnosis should be before the complication. Because if the complication occurs, then anybody can diagnose. So how we diagnose rheumatoid arthritis? Rheumatoid arthritis is diagnosed basically if hand joints are involved. So you can see these are the hand joints. So 99% diagnosis is done by what we call as polyarthritis. Now, what is polyarthritis? Polyarthritis means arthritis of many joints, not one joint. So arthritis ideally should be ideally should be of the hand joint. But earlier we thought hand joint arthritis is ideal, but other joints can also be involved. So any joint like knee, shoulder, elbow, And there are three things. One is called as polyarthritis, another is called monoarthritis, and third thing is a oligoarthritis. So rheumatoid arthritis is a disease which is called polyarthritis. So more than four joints are involved. So you must remember, for a beginner, that rheumatoid arthritis is a polyarthritis. Rheumatoid arthritis is mostly the hand joints arthritis, but other joints can also be involved, like knee and ankle. Third thing is, it is a most of the patient will have an inflammatory arthritis. Now, what is inflammatory arthritis? Means the symptoms are worst in the morning. So basically, if you ask patient what time your arthritis is worst, doctor, when I get up in the morning, I am worst. So that is a time when, so that is the take after say rest of 3 to 4 hours, you become worst. And in fact, once you move your joints, you become better. So that is called as inflammatory arthritis. So I told you three things. It is classic rheumatoid arthritis is not monoarthritis, it is polyarthritis. So remember polyarthritis, remember arthritis of hand joint, remember uh, the inflammatory nature of arthritis means once you take rest, it becomes worst. So that is the three things. Now, fourth thing is chronic arthritis. Chronic means somebody comes for hardly, say somebody says I have arthritis for 10 days. 10 days does not mean chronic. Chronic means more than 6 weeks. So somebody has arthritis for more than 6 weeks. So that is a chronicity. So chronic arthritis. And then the rheumatoid factor is positive in 70 to 80% patients. And anti-CCP is also positive in almost about 80 to 90% patients. There are two tests, rheumatoid factor and anti-CCP antibody. Now, these are not diagnostic, but they help you. Why I told you, suppose a normal person, suppose like me, if you test my blood and rheumatoid factor is positive, does not mean I have a rheumatoid arthritis. So you should have symptoms also. So symptoms of polyarthritis, hand joint arthritis, inflammatory arthritis, and chronic arthritis, plus if rheumatoid factor is positive, then you are very comfortable in making the diagnosis of rheumatoid arthritis. But rheumatoid arthritis is positive only in, say, 70 to 80% of patients. Anti-CCP is also positive in about 80 to 90% of patients, and anti-CCP is more specific. It means rheumatoid factor can be positive in many other diseases. Suppose somebody has a tuberculosis, then rheumatoid factor can be positive. Rheumatoid factor can be positive in many other diseases like Sjogren syndrome. It can be positive even lupus. It can be positive in many other diseases, including many other infections. So it is not specific. While anti-CCP antibody test is very specific. So that's why if anti-CCP is positive and these symptoms are there, so we are very comfortable in making the diagnosis. Yes, nowadays a lot of other things are coming. Like me, I was the first person in this country to start ultrasound of the joints. If you do the ultrasounds of early rheumatoid arthritis, then you can see synovium. The synovium, as I explained to you, is a disease of synovium. So how to see the synovium? Synovium can only be seen either by MRI or by the ultrasound. MRI is costly, while ultrasound is cheaper. So you do the ultrasound of the hand joints or whatever joints are involved. You can see the synovium is thickened. Synovium has increased Doppler signal. So you can demonstrate, yes, there is inflammation even at the early disease. So this is how these things are diagnosed. Suppose, sorry, uh, just a minute. Uh, I think, yeah. So what has changed in the treatment of rheumatoid arthritis? So first is the diagnosis. Diagnosis is purely clinical, which I told you. You ask the patient and the diagnosis is done bedside. And if the rheumatoid factor anti-CCP is positive, in 10% of cases it is negative. So you call them seronegative rheumatoid arthritis. Now, this photograph is very, very important for treatment purpose. That what is the understanding that there are two cells, one is called T cell, another is B cell, and these two cells, when they talk to each other, lot of cytokines are produced. Like old generation doctors are uh, uh, very familiar with hormones, so they may not be familiar with this, which is called as the which we call it cytokines. Now, cyto means cell. So these things are produced, and these things are called as cytokines. Now, these cytokines, they activate the synovial, they activate the B cell, and which produces the rheumatoid factor and other things, and they also activate vascular adhesion molecules. So these cytokines, they are responsible for T cell activation, regulation by cyt. So basically, if you remember this photograph, because somebody will ask you, what are the why such so many symptoms are there? Why there is a pain? Why there is a swelling? Why there is a fatigue? All because of these cytokines. So people are working to block these cytokines. So that is how the disease can be controlled. So this is the same thing, that this is one cell, this is another cell, and these are the these are the molecules which they talk to each other, and this is, so this is the TNF which is high, and you can the just a minute, please don't mind. There's some, yeah, this slide I wanted to show first, that initially in 1990, I joined rheumatology somewhere in 1990. In 1990, these were the drugs which was available: methotrexate, sulfasalazine, hydroxychloroquine, and gold. In fact, gold injection till 1990 they were used, and these all drugs were used. And then in somewhere in 1998, another drug came which is called leflunomide. Now I'll tell you a small history. These all drugs are called as the conventional disease modifying drug. Now, conventional means it is used for many years. So the oldest drug which actually is being used in this is gold, then followed by hydroxychloroquine, then sulfasalazine. These drugs are very old. Then penicillamine old, and azathioprine also. In fact, methotrexate came much later. So methotrexate came almost about in the 80s, methotrexate. And does anybody know who discovered methotrexate? Methotrexate was discovered by an Indian called as Subba Rao. And you'll be surprised that Subba Rao name is not there even in the textbook, because of Europe, because of the bias of people he was working with. And this is the time where we must say the world that methotrexate drug was discovered by a person called Subba Rao. And so these are conventional, including leflunomide. Now, methotrexate. Now, methotrexate, gradually the methotrexate survived. Most of other drugs are not much used, but methotrexate, sulfasalazine, hydroxychloroquine. Now, what is the difference between chloroquine and hydroxychloroquine? Chloroquine was a drug which was used for malaria. Same drug is used for the rheumatoid arthritis. But people realize there is a lot of eye toxicity, the retinopathy. So if you do the hydroxylation, then eye toxicity is less. It is absolutely safe. So hydroxychloroquine. Hydroxychloroquine is used about, say, 4.5 to 5 milligram per kg of body weight. Simple to remember, it is roughly for an adult is about 300 milligram. It is given daily, and it is given after meals. And how long? It can be given for a longer time, maybe 3 years, 4 years, 6 years, or maybe lifelong. Like you give treatment for diabetes or blood pressure, you give for longer time, you can use these drugs for a longer time. And uh, uh, once the disease become better, which we call as minimal disease activity or maybe complete remission, then it can be dose can be reduced. Maybe you can do this called tapering. We can generally, which will take 2 to 3 years, and then you can make it maybe alternate day, maybe reduce. Then the next drug is methotrexate. Now, methotrexate is a weekly drug. So methotrexate is the gold standard drug. Like you have diabetes, metformin, same is methotrexate. Methotrexate is given weekly. Methotrexate is preferably given in the night. The only thing which has changed is that methotrexate earlier was given in the low dose, that is 7.5 milligram, and now it is given roughly 15 to 30 milligram per kg, 15 to 30 per week. What methotrexate does, it basically affects the purine metabolism, and since it affects the purine metabolism, so the inflammation in a low dose, a lot of people say methotrexate is a drug for cancer. Yes, it is also used for cancer, but in cancer it is used in a very high quantity. So high dose, if you use, it is uh, anti-cancer drug. But if you use low dose, it is for immune inflammation. So methotrexate is a drug which is given for the immune inflammation. The methotrexate causes the dampening of immune inflammation. Every aspect of immune inflammation, whether T cell, B cell, immune production of cytokines, everything is dampened and heals the erosion. How long it can be given? So you give this dose of 15 to 30 milligram, depends. Normally, average dose you remember about 15 milligram. It can be given again for a long time, maybe lifelong. And once you achieve the remission or even a low disease activity, you can reduce the dose. What are the side effects? The side effect of methotrexate is the most important side effect of methotrexate is nausea. And when we give weekly, I always explain that you take on Sunday because that is how they remember. And Monday you take folic acid because to minimize the side effect, one tablet of folic acid. So a ideal prescription is methotrexate 15 milligram every Sunday after dinner. On Monday, you take folic acid 5 milligram per week. The side effect is nausea. We explain to the patient, if some, say, 100 people are taking methotrexate, about 5% people will have nausea, which will be gradually, once you use it, it will subside after some time. Or you can use some S2 blocker or antacid. So that how it can be minimized. Sometimes it can be very, very severe nausea and patients virtually refuse to take methotrexate. Then you can use parenteral methotrexate. Nowadays, parenteral methotrexate is also available. So in two conditions, we use parenteral methotrexate. First thing, patient cannot tolerate. Secondly, if your 15 milligram dose is not working and you want to use higher doses, say 20, 25 milligram, then the oral drug beyond 15 milligram absorption is little poor. So use the high, for a higher dose, you use the parenteral injections can be used. Methotrexate, other side effects of methotrexate can be cytopenias. It can be even rarely it can cause the hypersensitivity pneumonitis. It can you can have acidity. So even hydroxychloroquine can also have a lot of the dyspeptic symptom. So we hydroxychloroquine, if you, a lot of people ask whether hydroxychloroquine cause retinopathy and how it can be prevented. For, let's say, about, if you take for 4 or 5 years, it is very safe. After 5 years, you must do the eye test. So eye test, you send to ophthalmologist, and they will see for the fundus. So that is hydroxychloroquine. What is sulfasalazine? If you ask me, the methotrexate and sulfasalazine both has equal efficacy. Sulfasalazine dose is daily, so you have to take daily. So you have to choose a drug between methotrexate and sulfasalazine. I will definitely choose a drug which is weekly. So sulfasalazine is daily. It causes acidity, and we have to tell the patient it may cause acidity. So that is the, sometimes it can cause even high colored urine also, and very rarely it can cause the sperm count, a little less sperm count. So that is the how the sulfasalazine and methotrexate, they differ. Now the next drug is the leflunomide. How the leflunomide differ from the methotrexate? First thing, it is a daily dose, about say 10 to 20 milligram. And leflunomide, biggest problem with leflunomide is that it can cause hepatotoxicity. So it has more hepatotoxicity than this. Otherwise, so how these drugs, when they use, how, what we tell patient, that you get your blood test done every 1 month or 3 months. So 1 to 3 months, you do the blood test. What blood test? That is the CBC, creatinine, and SGPT. So why it is done? We want to be sure that kidneys remains the okay. So you get a creatinine, and you get a you get the so the CBC, creatine, SGPT. So SGPT is every for the liver. So this is how. Now, when these drugs were using, when we're using all these drugs were okay. So yeah, so this is the DMARDs where, so these are called disease modifying drugs. I explained to you about these 4 drugs. Then what happened? Either you can use a single drug or in combination. Currently, the guideline says you first you use the methotrexate alone. If methotrexate is intolerance or methotrexate does not work means you wait for about 3 months. So you use for 3 months methotrexate in a good dose, say about 15 milligram. If it is not working, make it to 20, 25. And in 3 months, you realize that if it is not working, then you can either use a combination. So you can use combine with any of these drugs, or you can use the single drug, like you can use, you change the methotrexate and give it leflunomide. Now, suppose all this fail and you're using methotrexate, then you can use other drugs also, which are called as biologics. So these are the biologics. And these biologics, I'll explain to you what are these drugs. So what had happened, I'll come here straight away. Sorry, I mix up some slides. So when the disease modifying drugs fail, if these drugs fail, then we have other drugs which are called anti-cytokines. And anti-cytokines are, these are the cytokines which I was telling you. And these cytokines can cause inflammation, which I already explained to you. And the drugs are used against these cytokines because they demonstrated, once you do a synovial biopsy, rheumatoid arthritis has a TNF which is high. So if the TNF is high, the cytokine TNF, this is the staining for the cytokine. So this is TNF, this is TNF, this is TNF. So they made a drug which is called as anti-TNF drug. And this was made by a Indian. So I salute him. And this was the first paper on infliximab. The drug was called as infliximab, which was against anti-TNF. And this anti-TNF drug was first published by this man called Ravinder Mani and Mark Feldman, and they came on the main cover of Arthritis Rheumatism, which was unusual for a scientific journal to carry a photograph on the front page of the journal, and rest is the history. And they are called as wonder drugs. There's no wonder in the science, but yes, they are more effective drug, they are more costly drug, and they are more target. This was the first patient in this country which was given this drug, and I was the person we gave in army hospital, and she was a wife of a brigadier, and she was taking methotrexate very regularly. She was taking other combination drugs, but in spite of those drugs, and this was the year 2002, not now. And when we gave, uh, in spite of these tablets and a good treatment, she lost both her hip joint, both knee joint, and multiple joints. So it something had to be done. And then came this, that time the drug, anti-TNF drug came. Initially, these two drugs came, etanercept and infliximab. We had infliximab, and this was year somewhere 99 2000, and we used this drug, and since then we use in many patients. So this is the data of these biologics drugs, when we use in very early in this country when nobody was using it. So we use for about more than 100 patient infliximab, and this was the this is another drug which was used, etanercept. There are two anti-TNF drug, and about 100 patients, you can imagine, hardly any side effect, very less side effect. In fact, Western world thought that we cannot use this drug because they can sometimes cause more infection. But we realize over a period of time, it's not that. If you take the precautions for, especially for tuberculosis, then you will have less infections. Then another drug comes is rituximab and abatacept, then tocilizumab. Tocilizumab is a drug against the cytokine IL-6. Rituximab is a drug against B cell, and it's an anti-B cell therapy. And abatacept also basically against the co-stimulatory signal. So basically, just remember that there are a lot of choices in rheumatoid arthritis. You start with methotrexate. If methotrexate does not work, you increase the dose of methotrexate. If the methotrexate is not working, say you have used for 3 to 6 months, then either you can use combination or you replace with leflunomide, sulfasalazine. And if they also don't work, then you can switch out the biologics. Which drug should be used? You can use this. Normally, we start, actually speaking, is with the anti-TNF, and we have another drug, rituximab. So this all can be used. So you have lot of choices. This I have already told you. And that time tuberculosis was the fear that a lot of patients will develop tuberculosis, because we are using anti-TNF drugs can cause tuberculosis. And so I said, you don't use the drugs which is used as it is used in European country. That is these are the drug, you give the loading dose, you don't give the loading dose. So I stopped the loading dose and just give this 8 weekly, and we presented our work also, and we said, look, there is no tuberculosis. Tuberculosis is still fear. So it can cause present, if you're using biologics, can present as this was our one patient was a senior person, and he developed this swelling. We thought it is tuberculosis, it turned out to be lymphoma. So it can rarely causes the malignancy also, but over a period of time people learn, no, I think the incidence of cancer is not high. So probably it was just a coincidence. It can cause tuberculosis. It can cause miliary tuberculosis. I'm talking biologics, anti-TNF. It can cause pneumocystis. It can cause fungal infection. Etanercept injection can cause the. Then came, look, you have used the traditional drug, you have used the biologics. Biologics are costly, and even then some patients are not responding. So then came the the what is called as small molecules. Now, large molecule is the biologics. Why they are called large? Because they are more complex, difficult to make. And then came the new set of drugs, which was called small molecules. And these molecules, advantage of these molecules were they were as effective as the biologics, and they were called as small molecules. And these drugs are called JAK inhibitors. They are oral drugs. They also work rapidly, but they also can have infections like tuberculosis and all. And these drugs are called as the JAK inhibitors. And so JAK inhibitors means Janus kinase inhibitors, and they block the cytokines. So that is the how the if you explain to me, so they are the they block the receptors, and these are the receptors, and they block these signals. So that is how the JAK inhibitors work: JAK1, JAK2, JAK3. So different cytokines they can block. uh, the they you can block JAK1, you can block JAK2, or you can block JAK3 or other cytokines. So that is sometime we'll talk on this. The classification of the JAK1 inhibitors. Don't get scared. Every year, new JAK inhibitors will come. Simple to remember that whatever is available in our country, what is available is the tofacitinib. So tofacitinib and baricitinib, they are two drugs which are available in this country. And they if you ask me why they are used, because there is activation of this pathway in rheumatoid arthritis, JAK-STAT pathway. So you block this pathway, rheumatoid arthritis is the this effective in rheumatoid arthritis. So the tofacitinib in rheumatoid arthritis, so it is approved in 2012. And as I said, there are three JAK inhibitors: JAK1, JAK2, JAK3, and TYK2. Generally, we target JAK1, JAK2, and JAK3. So this we can skip. This is the I think we should not go in this, but that is how the JAK works, and they activate the pathway, and we block those pathway. The inhibition of JAK1 and JAK3 is the main target. So they are the target which is these are the studies which is for the JAK inhibitors. So they respond beautifully as early as 1 week, and uh, the ACR responses can be achieved early. So they are basically rapidly acting, and these are the studies. But since we don't have time, so you must remember that there are some studies like START1, SCAN. So they are the drugs used. They are the studies like any other drug. They were also studies. So I'll come to the side effect is probably the herpes zoster. You must remember one side effect that is it can, especially JAK inhibitors, can cause tuberculosis less, and sometimes it can cause thrombotic episodes. This is an Indian study in 2018 that our experience says yes, they are well tolerated, and incidence of tuberculosis also minimal. So if you see this table, which is real world data, that uh, generally they are stable, and serious infections are less, and herpes zoster still remains the concern. So we must explain to the patient. Uh, to summarize, we have come long way. Immune inflammation is addressed, but damage, fatigue, pain, weakness are is the problem. Current era, we are using more JAK inhibitors. So thank you so much. Probably this is the last slide, and thank you for the patient's hearing. Just to summarize that the when we started with methotrexate, then after methotrexate came we started with the gold therapy, because we didn't know how to treat rheumatoid arthritis. Then came hydroxychloroquine and drugs like d-penicillamine. Then came the gold standard drug methotrexate, which is still used. So you must know that methotrexate is a gold standard, which can be used as a single drug. The advantage of methotrexate, it is a weekly drug. If methotrexate does not work, then we have other drugs also. And if these drugs also don't work, then we have cytokines. These anti-cytokine drugs like infliximab, anti-TNF drugs or rituximab. But these drugs are injectable. So people were searching for an oral drug, like people are searching for an oral insulin. So they came the JAK inhibitors. The JAK inhibitors, advantage of JAK inhibitors is they address pain also. So pain is addressed. So JAK inhibitors are very good drug, except that we must know that the it can sometimes cause herpes. Their advantage is you don't require a fridge to store it. They are oral drugs. Patient, advantage of patient is that patient likes oral drug. So current era probably belongs to these drugs called JAK inhibitor. They should not be misused. They should only be used when methotrexate and other drugs if they fail. Thank you so much. Thanks for the patience hearing. Thank you so much. Jai Hind.
Thank you so much, sir. Thank you for your enlightenment talk and for enriching experience you have shared over your PPT. Thank you so much for that. We have received few questions from the participants. So with all your due permission, I would like to put across those questions to you.
Yeah,
So the
I can still wait. I can still take for the next 5 minutes.
Sure, sure, sir. I'll not take much of your time. So the first question is, what are the potential long-term complications of rheumatoid arthritis and how can they be prevented or managed? Well, we have covered this as well in the talk, but yet I would like to ask you because it's from our viewer.
So any chronic immune inflammation will have biggest problem will be that the destruction of the cartilage. Once so destruction of the joint. So that is number one. Secondly, the dreadest first complication is infection. Now infection can be because of the disease per se, because rheumatoid arthritis can decrease the immunity. And the biggest problem is the drugs which were used that they can also cause infection. So infection, destruction, that is a disability, and the amyloidosis. Because in earlier era, tuberculosis was not treatable, and any long-term infection or inflammation can lead to amyloidosis. This amyloid material is deposited into various tissues, especially in the kidney. So that can cause amyloidosis. So amyloidosis is thus, yes, it can affect many other organs. It can affect eye. So you have a problem in the eye. It can affect the even lungs. So you can have interstitial lung disease. So all those other issues are also there. So issues can be because of the drugs, or issues can be because of the disease itself.
Thank you so much, sir. Thank you for answering that question. We will take one last question and then we will conclude, if you allow, sir.
Yeah,
Yeah.
please.
So the last question is related to the implications. What are the implications of personalized or precision medicine approaches in the management of rheumatoid arthritis?
Look, everywhere, especially these things came from oncology. Probably we realize that same drugs cannot work for a standard protocol does not work for all the patient. So some patient respond, some patient don't respond. Some patient respond beautifully. Some patient says, look, these are not working, neither the disease modifying drugs working, not cytokines working. Some are absolutely refractory. So people realize there are some factors, especially genetic and epigenetic factor, and they start working in oncology. And a great work has been done in oncology, and they know, okay, this if this is the gene and epigenes and for this Hodgkin's, then they will respond to this drug, or they may not respond to this drug. Same thing is happening in rheumatology today, but that success of rheumatology is not very good even now, because DR4 is a gene associated with the rheumatoid arthritis, but the precise medicine or personal medicine still will wait. A lot of work is going on. What are those factors which can decide which drug for which patient, and what are the drugs used for refractory diseases? which is the drugs, which is it a T cell disease or it's a B cell disease, whether we should give anti B cell therapy or we should. So that time has not come, but work is already going. As on today, we know that if you want to use a patient who is a rheumatoid factor positive and high titer, they respond more to rituximab. And if rheumatoid factor is negative, then anti-TNF drugs are used. So if it is positive, rituximab, but that has not come as a conclusive evidence. So we have to wait for these answers for personalized medicine, as has been done in oncology.
Thank you so much, sir. Thank you for answering that question and all the other questions for our viewers and for making them understand about the topic in such a better manner. I would like to thank all our viewers for their ardent participation that they have shown by staying tuned with us and by putting across such interesting questions to us. And I would like to thank you, sir, for taking out your valuable time from your busy schedule and for being here at our platform and sharing your wonderful insights with us. Thank you so much, sir.
Thanks. Thank you so much. Thanks, Jane.
Jai Hind, sir.